some speakers also mentioned that we see the auditorium empty.
Has to sort of calculate and take the auditorium of that size.
Yes. Yes, because they had estimated approximately 500 attendees every day. So, keeping that in mind, that huge was the auditorium.
It's probably good. Just a bit of lot of
Yes.
Today's webinar is on chronic lymphocytic leukemia colloquium, including the best of EHA and ASCO in the field of management of CLL. This webinar is brought to you by Mumbai Hematology Group. It is supported by AstraZeneca and PharmaFir. It's managed by Perfect Square. I thank Dr. Shweta Surve and her team from AstraZeneca, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker of the day, Dr. Wojciech Jutek from Poland, all our guest speakers from India, and all our discussants were themselves eminent hematologists or medical oncologists. And you participants for sparing your Friday evening if you are from India, and morning or afternoon if you are from somewhere else. We begin with our first talk of the day. Our guest speaker for the first talk is Dr. Srinidhi Nathani from New Delhi. She's attending consultant, Molecular Diagnostics Section, Department of Pathology at the prestigious Rajiv Gandhi Cancer Institute and Research Center at Delhi. And she is going to speak on importance of cytogenetics and prognostic markers in chronic lymphocytic leukemia. Over to Dr. Srinidhi.
Thank you, sir, for the kind introduction. Can I share my screen?
Yes, please.
So CLL, first of all, good evening everyone and a very happy Doctor's Day. And thank you for giving me this opportunity to talk on a topic which is very, very close to my heart. And importance of cytogenetics and prognostic markers in CLL. Basically, it's very, I cannot change my slides. I'm unable to change my slides. Yes. Okay. So this quote, something old, something new, something borrowed, and something blue.
You cannot see your slide now. You want Kalpesh to display? Oh, no, we got your slide again, yeah.
Okay. So basically this famous quote is from the White Weddings, something old, something new, something borrowed, and something blue. It goes very well with how the CLL genomics and cytogenomics and prognostic markers have evolved. And I'll tell you as and when that happens. So when you're asking me to start my video, that is where my slides are getting stuck. I'm so sorry.
Close your video.
Yeah, it's closed, but once the host asks me to start sharing, then that happens. Okay, so so that's where it's getting stuck.
We ask Kalpesh to play.
Yeah, we can ask him to play.
Kalpesh, please go ahead.
Next slide, please. So why are we discussing this today is because CLL was an entity which was initially known for smudge cells and being positive for CD5 and CD23 and is now known by TP53, ATM and IGHP mutation status. Next, please. And once it was known famously by the Ryan Binet staging, and now everyone talks about International Prognostic Index. And we have the new BTK inhibitors as targeted therapy apart from the chemoimmune therapy. So cytogenetics and next slide, please. Cytogenetics and genomics of CLL. What should you know? And most importantly, why is what I'm going to be talking about. That why should we test and what should we test and how should we test? Next slide, please. So if you see the prognostic marker spectrum in CLL, apart from the normal patient characteristics and the known biomarkers and biochemical markers like LDH, beta-2 microglobulin, and the famous CD38 and ZAP70 cytometry markers, we also have a lot of molecular alterations other than the known cytogenetic abnormalities, the famous TP53 deletion 17p, which is known to be bad. So in this grid, the things which are important other than the already known things for me now, which excites me, is the IGHV mutation status, because the ERIC recommendations have started uroclonality by NGS, and they also tell us that in the report we should mention VH321. So at RGCI in our reports, if you have had a chance to look at our reports, we definitely highlight VH321 and 169 as well. And other gene mutations have now become important in the era of NGS, basically because we have a lot of mutations which we can test using a panel based testing, and we are fortunate enough to have all the genes which are mentioned here. And epigenetic signature is something which we are now starting, because there are a lot of microRNA expressions like microRNA 142, 151, as well as there are some histone somatic mutations which have also surfaced, which may be important later when we get more studies. Next slide, please. So why are we testing is because all the guidelines are mandating, including NCCN as well as IPI. And if you see the highlighted grid, you can see TP53, you can see IGHV, you can see deletion 11q, you can see complex karyotype. And CLL IPI, the highest score is for deletion 17p and TP53 mutation. Next slide, please. So, what do we test and how? So, the something old part of it, according to my quote, is the conventional karyotyping. So, we all know complex karyotype is when you have more than 3 independent chromosomal aberrations. And now we have something called as high complexity karyotype, which has more than 5 aberrations. So, this is something which we have been doing from time immemorial when it comes to karyotyping and fish. And the new thing, the new kid on the block is the next generation sequencing, which is the third block, which tests for mutations in all these genes which have been listed as prognostic markers. Although the workflow is complex, although there are a lot of technical challenges, a lot of interpretative challenges, but this is what is now needed. Next slide, please. So, as I said, conventional karyotype, more than 3 aberrations and more than 5. So, if you see the Kaplan-Meier curves, the lesser aberrations, the patient does better. When it goes to more than 5, the patient does the worst. So, that is what is now known as high cytogenetic complexity. And these are all independent prognostic biomarkers for adverse prognosis. So, and plus, if it gets aggravated with another TP53 aberration, then the patient does even worse. So this is something which is old, which we have always known, that any kind of complex karyotype, which means the genome is very busy, very unstable, so the patient does worse. Next slide, please. Something blue comes from the fish, because fish is blue because of the background staining. So fish, we can see the fish abnormalities, deletion 17p, 11q, trisomy 12. So 17p definitely does the worst, whereas if you see 13q, they do better. And trisomy 12 for me is equivocal, kind of, because it depends on a lot of other factors as well. Although there are a lot of cases which have very high CD38 expression, which is an adverse marker. Plus, they are usually unmutated, although in my experience, they are, half and half more, they can be mutated as well. So, and plus, there are a lot of concurrent mutations in trisomy 12, especially Notch1 mutations are very commonly seen in trisomy 12 altered CLL patients, which again is an adverse prognostic marker. Next slide, please. 11q deletion, although in Asians we get it a little rare, 7 to 12% compared to the West, but obviously ATM unfavorable. There are other genes like MLL, RDX, FDX on that locus, and they are all involved in this. And this patient presents with a very bulky disease. They are very rapid progressors, and 30% of them also have corresponding deleterious ATM mutations. So this is where the importance of NGS also lies, that if you have an 11q deletion compounded by a corresponding mutation in the ATM gene, patient will do even worse. Next slide, please. So something borrowed is the elephant in the house, which is the TP53, which is there in every malignancy. And now we no longer only say deletion 17p or TP53 mutation, we call it TP53 aberration. So deletions are seen in 10% cases, whereas mutations are seen in 2 to 5% cases. And if you see this diagram, the normal is when the entire TP53 gene is intact. But there can be a deletion of the P arm, that is the second one, the short arm is deleted. But the most common is that this short arm is deleted on one chromosome and the other chromosome has a TP53 mutation. So this patient is actually going to do very bad because it kind of, when you look at the mutation on NGS, the variant allele fraction can be as high as 70 to 80% because probably one TP53 is deleted. So automatically the mutation load also comes out to be high. So it can undergo any kind of copy neutral loss of heterozygosity as seen in the last one. Both alleles can be mutated, one can be mutated, but the most common is this. So actually the most common is when you have a mutation, so it is important to do an NGS because it is difficult to do Sanger. So this is important because TP53, there are a lot of recommendations from Eric, European recommendations for TP53 reporting. So why we can't do only one test? We cannot do only fish and leave it at that because fish is going to only tell you deletion 17p. You have to know whether there is any other mutation in TP53 gene or not. For doing that, we have Sanger, we have NGS, but not because I'm a molecular pathologist, I'm going to recommend NGS, but because of the sensitivity, because of the higher throughput, because the TB53 is a big gene, and to cover a big gene, doing Sanger sequencing is going to be very, very laborious. It will involve a lot of reactions, a lot of technical errors. There are chances of interpretative errors. There are chances of false negatives. And plus Sanger, we know the sensitivity is 20%. It is not going to pick anything which is less than 20% mutated. So NGS is the key, and that is why we have introduced panel-based testing for NGS and CLL. Next slide, please. This is a famous IGHV which all of us talk about, and this is probably one of the very few genes which, when mutated, is good and unmutated is bad. So when we talk about mutated IGHV, why are they good and why unmutated is bad? So if you look at the genome and if you look at the pathway which is there, CD38 expression is higher in IGHV mutated patients. They have higher ZAP70 expression. The genome is very, very busy. There's a lot of instability. The telomeres are very short, so obviously they are going to do bad. Whereas if you see the mutated patients, they have long telomeres, the genome is relatively stable, there are going to be less karyotypic abnormalities, plus the CD38 expression is low, so they are going to do better. So again, for testing this, we have, next slide please. As Eric has recommendations for both Sanger as well as NGS. NGS is under the Euroclonality study as well. So Sanger sequencing, although cheap, the TAT is shorter, but nowadays, even Sanger, if you're going to go and do IGHV testing, you don't know whether you're going to get productive sequences, you're going to get correct true sequences, because it involves two steps. First, you have to do a fragment length analysis, find out what is clonal, then go and sequence it. It is labor intensive. There are a lot of interpretative errors. Plus, you have to do immunoinformatics with the Sanger sequence data to actually come out with the actual result. Subclonal architecture you cannot make out. You cannot make out whether how much intraclonal diversity. We measure it using Shannon diversity index. You don't know that, you cannot make that out in Sanger sequencing. Whereas in NGS, when you do NGS, you can know the subclonal architecture, you can find the Shannon diversity, you can find intraclonal diversity. Plus, you can actually, the throughput is high, you can actually run a lot of cases together. You can actually, the TAT will be longer if you have lesser samples, but if you have more samples, like we end up running an IGHV panel almost every week, because considering the kind of load now we have for CLL. And plus the interpretation, although this study which was done and which was published in Leukemia says that the interpretation is difficult because it has dedicated informatic tools, but nowadays that workflow also has been very simplified and optimized for us, and there are a lot of validated workflows available which has made interpretation very, very easy for this. And I wish I could show you, but then I don't have that data right now. But IGHV mutation status is either pink or white, and if it's pink, it's mutated. If it's white, it's unmutated. That is how we have learned when we have learned NGS for IGHV mutation. And last but not the least, because BTKI inhibitors are being used, we get a lot of BTK mutations and PLCG2 mutations. But surprisingly, in our experience, we are also getting a lot of BTK and PLCG2 heterozygous mutations in treatment naive patients. We do not put it out on the report because it makes no sense, because these are tyrosine kinase inhibitors and you need kinase domain mutations as resistance mechanisms. So we don't want to confuse the clinician and we don't put it out on the report. But then that's what we are getting in the Indian genome. We are kind of compiling that data because we are suspecting maybe there's some predisposition factor, but there are a lot of mutations which are coming even in the patients who have received treatment. The classical mutations, resistance mutations also we are getting. So this is also important to test. So any panel of CLL should not only be prognostic, it should also include these two genes which can cause resistance to uh, ibrutinib and acalabrutinib treatment, which is instituted in CLL. And I would want to share our experience. This is our recent short experience from RGCI, because this is important, I feel, because when we compare IGHV mutated and unmutated patients, so all the clinicians end up first asking for IGHV mutation status. So, looking at the mutation status, you can actually make out or actually kind of guess that what other genomic or cytogenetic alteration you're going to be looking at. So, if you actually see, it is the TP53, SF3B1, BERK3, ATM, which are usually unmutated CLLs, and you expect that because they are also bad and unmutated CLLs are also bad. Whereas trisomy 12, kind of equivocal for me, BERK3 also kind of equivocal for me. Deletion 13q, you expect them to be good, and they are also usually mutated, and not too many cases are unmutated. And so this is what is important for clinicians, is because they end up asking us that why do you want to do panel based testing, why can't you only do a CLL fish panel which has TP53, ATM, 13q, trisomy 12, and do an IGHV status. But it is important because SF3B1 patients are going to do bad, BERK3 patients are going to do bad. Then you may find a BRAF V600E sometimes, you can find an MYD88 sometimes. So it is important, a notch1 mutation sometimes. Thing with notch1 is that even the non-coding regions are mutated, especially in the 3' UTR. It is important to sequence that as well, because those patients are going to do bad. So it is important that you do cytogenetics and genomic alterations in all patients of CLL, not only IGHV mutation status and not only fish testing. It is important that you do karyotyping, you do an NGS test, because it is going to tell you other genomic alterations as well. Thank you.
Thank you, Dr. Srinidhi, for that elaborate talk, very comprehensive. We'll move on to the second lecture of the day, and it's my pleasure to introduce Dr. Chirag Shah. He is Director, Department of Hematology, Oncology and Stem Cell Transplant at Apollo Hospitals, Ahmedabad. He's going to speak on chronic lymphocytic leukemia with comorbidities, how to treat. So, Chirag, over to you.
Yes, sir. Kalpesh, can you put on the slides, please? Thank you, Dr. Agarwal, MHG, and AstraZeneca for this opportunity. And happy Doctor's Day to everyone. Next, please. So first I'll show a couple of cases very briefly. 73-year-old man with hypertension, CKD with a creatinine of 2 and history of pulmonary embolism on dabigatran. So clearly multiple comorbidities, classic patient, elderly. So this patient, I chose to go on BTK inhibitor instead of chemotherapy. Next. This is a 68-year-old man with CLL, now requiring treatment after a few years of follow-up with me. He is diabetic and fairly fit, but he lives about 8-10 hours distance. His is not in a big city, and limited follow-up is feasible. So again, I started him on BTK inhibitor, acalabrutinib, because of the concerns about follow-up with chemotherapy. Next, please. So I think most of you are aware of the CIRS score with comorbidities that we evaluate in a patient with CLL. And as you can see that the number of comorbidities listed here are fairly common, and that in elderly age group, and even a few 2 or 3 comorbidities can put this patient into a score more than 6, and CIRS more than 6 are considered difficult or higher risk for chemotherapy. Next. This is one of the algorithms for CLL management. And what I'm trying to highlight here is that if you see now practically whether the patient is fit or unfit, IGHV mutated or unmutated, and whether there is TP53 deletion 17p present or absent, in all the groups, the BTK inhibitors and BCL2 inhibitors, venetoclax, are there. So these have become kind of, they have neutralized the importance of so many factors that we had to look at in deciding what option to choose. So this has made life easier for CLL in general and much more so for patients with comorbidities. Next. So the options that we have are continuous therapy till progression with BTK inhibitors, that is imatinib, ibrutinib, acalabrutinib, and venetoclax, the ones available easily in India. Next. And the recent concept of fixed duration therapy with venetoclax plus rituximab or obinutuzumab and venetoclax plus BTK inhibitors, a very recent option. And the older ones, which we most commonly still use, are the bendamustine rituximab or chlorambucil plus minus rituximab or obinutuzumab, and in some patients, FCR. Next. So clearly, the BTK inhibitors have become mainstay of treatment now all over the world in CLL. And as we discussed earlier, they are practically suitable for all types of patients, whether patient is fit or unfit, IGVH mutated or unmutated, and whether deletion 17p is present or absent. And the earlier what we mentioned, the CIRS score of 6 or more and GFR less than 70 were the trial entry criteria in the initial studies of BTK inhibitors, which are considered high risk for the FCR or BR regimen. Next. Now we know that most patients with CLL have comorbidities which can complicate treatment, and this includes, the study showing that 89% of patients had one or more comorbidity, and 46% had at least one major comorbidity. Geriatric patients on the geriatric tools show significant score of frailty, and 2 out of 3 studies that frailty increases the toxicity. So even if the patient has no obvious major comorbidities or minimal, for example, only hypertension and diabetes very well controlled, uh, and you may feel that the patient is very fit, but on a frailty index, they may not do so well, and this also correlates with toxicity. So, this is something we are not used to analyzing frequently, but it may become important, especially in patients over the age of 70, 75, which is an increasing group now in India also that we are frequently treating. Next. We know that the what are these major comorbidities? So, importantly, 46% hypertension, 16% coronary artery disease, and 13% other heart disease, and 45% have rheumatologic problems, joint diseases. Next. Next. So the 8-year follow-up. So now back to the BTK inhibitors, that the longest follow-up is from Resonate 2, where ibrutinib monotherapy continues to show good benefit compared to chlorambucil, with uh, no major long-term safety concerns as well. Uh, so, a drug which can be continued for long and fairly safely. Next. Now, uh, the uh, the long-term data along with this also shows that in real life practice, the 15 to 23% of patients end up discontinuing because of the various A's, and 15 to 20% require dose reduction as well. Next. One important concern with ibrutinib has been as seen in this phase 3 data from the NCRI FLAIR, is uh, uh, sorry, it's, can you go to the next, please? So, in this slide and the next one, we can see that the toxicity rate, the side effect profile of the two combinations, the two treatment arms, FCR with more of the hematological malignancies in the long run, secondary hematological malignancies, infections, and rectal transformations. And in the ibrutinib arm, it is non-hematological malignancies as well as the cardiac and hypertension, which are well known to us. But uh, the PFS with IGHV mutation status, the both are same, and without IGHV mutation status, so ibrutinib is better. So once again, in every subgroup, it works better as you discussed earlier, or equal. Next. But yes, the one of the important point in this study and in other studies also has been sudden unexplained death or cardiac death with ibrutinib, which is although very rare, but is an important concern, because in a disease where otherwise we are expecting fairly long survival, this becomes an issue. And as you can see in this, that this data, the in FCR, that number was only 2, and in the ibrutinib arm, it was 8. And patients who had underlying hypertension or cardiac disorder, the proportion was higher. that is 7 patients, and those who did not have any hypertension or coronary, it was only 1 patient. And this is seen in other trials also, including Alliance, Illuminate, Resonate, Genuine, and Helios. Next. Next, please. Now, the second BTK inhibitor, acalabrutinib, with again in a good long-term follow-up in Elevate TN, it shows that there is a sustained PFS benefit with acalabrutinib plus minus obinutuzumab compared to the control arm, and a good long-term safety as well. This is a 4-year follow-up. Next. Another study of acalabrutinib in patients who were ibrutinib intolerant. And again, it has showed good tolerance. Next, please. So good response and with good duration of response, as well as the tolerance. I think it's the next slide. So yes, so recurrence of AEs after this is a recurrence of AEs commonly leading to ibrutinib discontinuation, which again we are aware the atrial fibrillation, diarrhea, arthralgia, rash, and bleeding. Next. So the BTK inhibitors toxicities, the common ones are the arthralgia, diarrhea, rash, hypertension. Very interestingly, hypertension incidence continues to increase with time. So unlike most of the other side effects, which are seen mainly earlier, and if not seen in the first several months, then the incidence is very low, such as atrial fibrillation and the bleeding and other side effects mentioned. Only hypertension keeps on increasing with time. So you have to be watchful for that. Additionally, fatigue, cytopenias can happen. Ventricular arrhythmia is extremely uncommon, but is an important concern and could be one of the reasons for those sudden deaths that we have mentioned. And it's a bit concerning when you have one such patient that you had told patient in the clinic that a very good long-term survival is possible, the drug is fairly safe, and then you have that event. It's very disheartening. Next, please. So in these various studies, these same side effects that we have mentioned have been highlighted. And you can see the percentage that arthralgia and AFib, hematologic bleeding, hypertension, and infection. There are variations in these studies from 5 to 10, 15% for these side effects in various studies. And that seems to be the kind of pattern in the practice also, that when we are talking to our Indian colleagues, as of now, at least my impression is that the discontinuation rate is not very high. And I would like to hear from the other colleagues during the discussion also on that, and what different patterns of AEs that they also see. Next, please. These are some of the other studies the percentage with acalabrutinib and zanubrutinib, and they are fairly similar with somewhat reduced incidence of atrial fibrillation and hypertension. And next, please. So, one important point about management of patients at relapse, the concepts remain the same as at the time of initial diagnosis. Uh, First, of course, confirm that diagnosis is CLL and that there is no Richter's transformation. If there is a sharp increase in LDH level, then this should be considered. Everybody who relapses does not need therapy right away, and that patients, just like we evaluate in the first line, that is the patient having indication to treat, means very rapidly progressive disease or bulky nodes or symptoms or cytopenias. So those are the main indications to treat. And there are patients who relapse but have low counts and none of these issues, and they can be followed for several months or so even after relapse. Next. Uh, in relapse refractory setting, acalabrutinib, uh, again, compared to the idelalisib or BR, showed better PFS, and in long-term follow-up, it has maintained the difference in PFS and the safety. Next. This is the Elevate RR study, where in previously treated patients, acalabrutinib and ibrutinib were compared head-to-head to see the difference in effectiveness and or safety. Next. The PFS is same with HR of 1. Next. The main difference is in the A's, where as you can see that on the grade 3-4 A's, the on the brutinib, the diarrhea, uh, arthralgia and hypertension is higher, the confusion and the atrial fibrillation, whereas headache and cough with acalabrutinib is higher. Headache is also very interesting symptom with acalabrutinib, which is mainly in the initial few weeks to months, and with caffeine intake, it reduces significantly. So the treatment, apart from any symptomatic medicines that you give, is to advise patients to have some caffeine. Next. Uh, Briefly, the fixed duration treatment, which we mentioned earlier, the venetoclax uh, plus rituximab versus BR, and that has continued to show good PFS difference and OS difference even 3 years after the end of treatment. So 1 year of fixed duration treatment attractive compared to the continuous treatment. However, utilized very infrequently still in India, at least because of the logistics of admitting patient initially for venetoclax, availability, cost mainly. Next. So last slide. So BTK inhibitors have definitely changed the management of CLL significantly and made life easier for almost all patients However, there are some unmet needs or maybe some areas where it is still not clear how safe these drugs are to use, and that can be discussed later. Is whether to use them with warfarin or other anticoagulants, or patients with significant active cardiovascular disease like difficult hypertension or recent procedure or symptomatic ischemic heart disease, very low GFR or on dialysis, and what to do for those who are intolerant to BTK inhibitors or venetoclax or progress on that and they cannot undergo chemotherapy. Next. Thank you.
Thank you, Chirag, once again for a beautiful presentation. And we'll move to our international guest speaker. We have Dr. Wojciech Jutek from Poland. So I'll just introduce you and then you can share your screen. So he's consultant and professor of hematology at Jagiellonian University, Krakow, Poland, where he leads the lymphoma team from 1992. Most of his research activity in the last 15 years was related to development of monoclonal antibodies in B-cell lymphomas and practical aspects of stem cell transplantation. At that time, radioimmunotherapy with yttrium-labeled ibrutinib tuxetin was being investigated, especially as consolidation of MCL and DLBCL patients, either in monotherapy or as an element of Z-beam conditioned autologous stem cell transplant. During the last decade in hematology, numerous drugs with an alternative mechanism of action to classical cytostatics were developed. At Jagiellonian University lymphoma that he leads, he has participated in over 70 clinical trials, including phase 1 and phase 1 followed by expansion cohorts. He is a co-author of publications leading to registration of ibrutinib, adalimumab, belinostat, lenalidomide, venetoclax, and rituximab biosimilars. At present, his research is focused on developing second-generation BTK inhibitors, anti-PD-1 molecules, DARTs, and BiTEs. He is a member of numerous scientific societies, ASH, ASCO, PLRG, EMCLN, ICOS, and consultant for EMA. His research papers were published in NEJM, Blood, JCO, The Lancet, Lancet Oncology, Annals of Oncology, etc., with cumulative I of more than 650, H-index 20, and citations over 3,000. I invite him to give a lecture on how do I manage chronic lymphocytic leukemia using novel targeted agents in combination, an update from EHA and ASCO. Over to you, sir. Sir, unmute yourself.
So let me welcome you warmly from Krakow. That's where I live. That's the main marketplace. Usually it's deserted. Now it's full of people, as perhaps for the first time in the history, we have refugees in Europe. In Poland alone, we have over 4 million Ukrainians fleeing from the war zone. And it does transfer to the patients we treat. 30% of the patients we treat at our department, at our lymphoma department at the moment, are of Ukrainian origin. So my presentation will be short, and to summarize it, there was nothing new during ASCO and EHA, mainly medical, uncore abstracts. So let me guide you through what we had. And so the three main questions remain the same. Should we use chemotherapy at all, or molecular targeted therapies? And I start to believe that even in Europe, because EMA was much more conservative, the era of chemoimmunotherapy is gone. Then, should we have continuous or time-limited therapies? And eventually, should the therapies be MRD guided, and what should be the combinations? The ASCO recommendations for the first-line therapy remain officially unchanged. We recommend wholeheartedly targeted therapies for the patients with TP53 mutation or 17p deletion. We recommend it also for other high-risk patients like IGHV unmutated status or those with complex cardiomyocyte cytogenetic changes or 11q deletion. But we start also to recommend it to the low-risk cases. And my way of understanding is that the countries like Poland, where there is no free access to BTK inhibitors, for example, also do not do the tests of mutation status of EGHV in all patients. And my way of thinking is that chemoimmunotherapy like FCR should not be given unless we are absolutely certain that we rule out not only 17p mutation patients, but also those with EGHV unmutated status. In the difficult cases, BTK inhibitors are doing pretty well. This is the summary of the studies with the first generation BTK inhibitor, ibrutinib. The second generation do even better. However, the first generation ibrutinib is jeopardized by reality, because in reality, a lot of patients have dropped out either because of developing of resistance or because of adverse events. And the abstracts of the German reality study was one of the few new abstracts presented on EHA. The acalabrutinib development was very consistent. And on EHA, we had an encore abstracts of the Elevate treatment naive patient study, where we took all elderly chronic lymphocytic leukemia first-line patients and randomized it towards acalabrutinib containing arms, either with or without obinutuzumab, and chlorambucil obinutuzumab, which was the standard at the time we launched this therapy. There was an evident progression-free survival. In progression-free survival, though, we haven't quite demonstrated a lot of differences between both acalabrutinib arms. If we looked at the high-risk patient, the same message. The BTK inhibitor did well. And if we looked at overall survival data, and this was something which might be new, there is a larger difference showing that there might be a significance of acalabrutinib combined with obinutuzumab, with a monoclonal antibody. In fact, there is a difference between this and acalabrutinib monotherapy, and so far we were rather reluctant to use it specifically in elderly patients because we had more adverse events. The other encore poster, which was presented, was the summary of CLL with high genomic features across different studies with acalabrutinib. And evidently, despite the line of therapy, the BTK therapy, the BTK inhibitor therapy is doing reasonably well in this high-risk patients. The frontline trial, the FLAIR, was presented as well, where FCR was randomized against ibrutinib given until the negativity for MRD. A clear difference, ibrutinib rituximab was better, also was better in high-risk cases. And as for time-limited therapies, the CLL14 study was presented, where venetoclax with obinutuzumab for 1 year was challenged against chlorambucil with obinutuzumab. Again, the progression-free survival difference was clear. However, if we looked at the high-risk cases, still the difference was great, but the time-limited therapy results were not as good as BTK inhibitor. So there was a rationale to combine BTK inhibitors with BCL2 inhibitors, as they both have a potential of both mobilizing the lymphoma cells to the niches where they could be eliminated more efficiently. And we observed this in a high-risk population, as presented here with TP53 alterations. That's the first line MD Anderson Cancer Center data, and that's ASH 21. And this combination, once compared retrospectively, was much better once we are talking about BTK inhibitors and venetoclax than BTK inhibitor on their own. Again, this is the MD Anderson data. There was an interesting study presented by Paulo Guia. Poor Paulo, he had COVID, so he presented from the screen. And it was the ibrutinib venetoclax induction regimen. Venetoclax was added after the first 3 cycles of BTK inhibitor to decrease the risk of tumor lysis syndrome. And then the patients with undetectable MRD were randomized between ibrutinib and placebo, and those where MRD was detected or not confirmed. There was a randomization between ibrutinib and ibrutinib plus venetoclax. There was a true high-risk population, and as you see, absolutely fabulous results. And those with confirmed MRD, we have the right to use placebo, and those with unconfirmed MRD, the maintenance with ibrutinib seems to be good enough. Numbers are small, but a very interesting protocol. Now, what do we have in a relapsing refractory setting? Here, we can say that even conservative ASCO, which is European guidelines, we recommend the targeted therapy for everyone. And certainly, we recommended more Bisley for those with high-risk features. But in fact, we should offer this therapy even to those with long-lasting remission after chemoimmunotherapy. So on EHA, we presented our old study, again, the ENCORE, where we challenged acalabrutinib to the physician's choice, but in fact, majority of our physician's choice was Idela plus rituximab. So this was the first study comparing BTK inhibitors to IP3K inhibitors. The population typical for relapsing refractory setting with 18 patients with 17p deletion, 25% of patients with 11q, 30% of patients with complex cytogenetic abnormalities, and a clear difference, clear progression-free survival difference. Now, it was a surprise to see that Idela plus rituximab didn't do extremely better than bendamustine to rituximab. At some stage, we had a study where we proved with Professor Zelenitz that Idela-Lisib combination was much better. It was not confirmed in this protocol. Now, the high-risk features like 17p deleted patients or those with unmutated EGHV status, there was also a clear difference. In all analyzed subgroups, we could claim for BTK inhibitor superiority, and this was something which was a surprise because we can prove the trend towards overall survival difference, and this happened despite the crossover design, with 76 patients, 49% of them being crossed over to acalabrutinib after progression. What we learned was that acalabrutinib was a safe drug, perhaps apart from the headache, which was common, all the other adverse events were not that common, and specifically the Idela rituximab was very harsh, and there were a lot of adverse events. Practically, we do not recommend this regimen any longer. As for the adverse events of special interest, the atrial fibrillation was kept low. if you looked at the incidence of major hemorrhages, it was low. And the other thing was, which was clear, was that although the infection rate was frequent, it was much less frequent than an IDELA arm. Another ANCHOR abstract was Elevate Relapsing Refractory, where acalabrutinib was challenged with ibrutinib. It was a face-to-face comparison in patients with high-risk features. The study met its primary endpoint. We had a non-inferiority, which was a primary endpoint. We had a non-inferiority proven in all subgroups, and perhaps one comment about atrial fibrillation. These are the data from CLL patients, which are elderly populations treated without BTK inhibitors. We have every year the steady increase of the incidence of atrial fibrillation, which is characteristic for this group. Now, if you're looking for ibrutinib, for acalabrutinib data, this is this curve which is in velvet and lower, it's exactly the same. Now, ibrutinib, it's twice as common, and so it happens with hypertension. Therefore, we must say that cardiotoxicity of the second generation BTK inhibitors is possibly not increased. As for other adverse events of special interest, the same story. We had another study comparing zanubrutinib to ibrutinib, and this data was presented last EHA. The zanubrutinib looked like it was a better BTK inhibitor. There was a progression-free survival significant difference versus ibrutinib, but the population was different. We took all, not just high-risk CLL patients. Zanubrutinib did absolutely fantastically with high-risk groups, and the same story with the atrial fibrillation and cardiac disorders. The adverse events of the second generation BTK inhibitors are much less prominent. But before we say hello, second generation are the best, I would just like to show you the data which were presented on EHA, again, the ANCHOR, the BRUIN study. It was the largest jumbo phase 1b study. Have you ever seen the phase 1b study, which has 618, now over 800 patients? But please forgive the Americans. They do things like that. So we had literally 300 CLL patients in the protocol with absolutely fantastic waterfall chart. And just I would like to draw your attention that dark blue bars are those which progressed on a previous BTK therapy, while light blue bars were those which were intolerant to previous BTK. So I want to underline the two things. First, the third generation BTK inhibitor does overcome the ibrutinib resistance. And secondly, it's much better tolerated. And it happens in all subgroups. The efficacy was proven in all subgroups analyzed. As you see, the mutation in cysteine 481 does not have any kind of impact on progression-free survival. The pirtobrutinib deals with it pretty efficiently. Here we compare the patients with and without their mutation. But here's the second thing I want to prove. We tend to say that the first generation BTK inhibitors are harsh, the second generation are very much well tolerated, and that the third generation are just more efficient. But pirtobrutinib is not just more efficient. Look at the adverse events. Look at the percentage of grade 1 and grade 2 adverse events, not talking about the serious adverse events. It's the best tolerated BTK inhibitor I ever investigated. And just to compare, there were nemtabrutinib data presented by Jennifer in ASCO, and it's also the third generation BTK inhibitor, but look, grade 3 adverse events, 74%, a lot. So the low the good toxicity profile might not be unique across the third generation BTK inhibitors. Now, talking about relapsing refractory cases, we can't forget a Murano protocol, which was not presented, but I brought that here just for you to remind it. I called it a victory under Murano, as this was the first time-limited protocol proving efficacy in relapsing refractory cases, clearly better than chemoimmunotherapy, with important overall survival difference as well. But it's dealing better, but not as good as BTK inhibitor in heavily in a high-risk population. So the difference between CLL14 and Murano protocol is that Murano protocol takes 2 years, CLL14 just 1 year. So it may give us a hint that in a high risk population, the length of therapy is important. And again, the Dutch presented a Hobbon study where we have a time-limited venetoclax plus ibrutinib. So we have an induction regimen and then randomization of ibrutinib until progression versus observation and retreatment and progression. You can see that the response after induction was absolutely great, regardless the high-risk group we analyzed. And it looks like we can clearly retreat the patients. The arm A and B are absolutely the same. However, I want to remind that the patients who are MRD positive have ibrutinib maintenance, all of them, and despite the maintenance, the result was inferior. So now what we are really looking forward to, BTK inhibitors plus BCL2 inhibitors. And we have the studies with ibrutinib, acalabrutinib, and zanubrutinib running. Now, a couple of comments I want to make here. You might have had the impression that zanubrutinib is a better drug based on non-randomized studies, better to acalabrutinib in terms more efficient. And yes, perhaps we can say that in a monotherapy studies, it is more efficient, but perhaps a relative dose of zanubrutinib is slightly higher. Acalabrutinib does the job and is relatively less toxic. Therefore, we are absolutely not certain about the result of the combo setting. I just want to remind you the number of neutropenias caused by zanubrutinib, which did not transfer to infection rate, as zanubrutinib is a selective inhibitor, which is not harsh on immunity. However, we don't know how this will behave in a combo setting. So take-home messages are that targeted therapy are undebatable standard in relapsing refractory cases, and they are moving to the first-line CLL. They are approved standard in all high-risk cases in the first line, and emerging standard for all CLL patients. By saying this, we have to add that we have to have the adequate COVID management, because the patients who are treated in a prolonged way are more prone to COVID. However, this is not as simple as you all know, that vaccination after the frank monoclonal antibodies may be inefficient. I just want to remind you the data that perhaps we could vaccinate the patients sufficiently 6 months after rituximab therapy, but there is no sign of response as long as 2 years after obinutuzumab therapy. Now, the second message is that new generation BTK inhibitors may prove to be better to ibrutinib, both due to better efficacy, but due to better safety. Now, the regimens with BCL2 inhibitors may allow for the time-limited therapy, and it's elegantly proven both in the first line setting and a relapsing refractory patients. However, we can't say which is better, BTK inhibition or BCL2 inhibition. In my opinion, they are alternative solutions. Neither may be regarded superior. and both have its shine and drawbacks. Long-lasting therapy may be more efficient in high-risk patients. However, it causes more problems, and definitely the adverse events, including COVID infections, may be more common. The time-limited protocols may be proposed on MRD basis, and here in CLL, MRD may have a different role than in mantle cell lymphoma. Because we had a long-lasting story of examining MRD status in mantle cell lymphoma, we hoped that MRD negative patients may be stopped on therapy. In fact, in mantle cell lymphoma, we learned the opposite. We learned that MRD negative patients may be treated as they were treated continuously for the better result. And the MRD positivity means the necessity of changing the therapy. The MRD status in CLL seems to be different. It looks like MRD negative patients may be safely discontinued on therapy and then retreated at molecular relapse. However, the randomized study is ongoing, and we are far from having a consensus in this issue. Therefore, once again, I would like to thank you for you attending this webinar, and remind you that in this quiet and peaceful marketplace, now we have crowds of refugees. Thank you.
Thank you, sir. Wonderful update, and you have covered it very in time also, so we have some time for some question answer. I'll ask the faculty present over here to ask some question, and the audience can put some question in the question box. Can I ask you one question? So with all these combinations coming up, would you favor a combination between BTKI with BCL2I, or you will use them with the monoclonal antibody one by one and keep the other one for the relapse situation?
It's difficult to say, but I would like to, there is one study in which we combine BTK inhibitor with BCL2 inhibitor and monoclonal antibody. And it looks like if we combine it, the BCL2 inhibitor and BTK inhibitor, there is an important increase of efficacy. The monoclonal antibody does not add a lot, and the vice versa. So perhaps the doublets are better than the triplets. So if you ask me what I would do, I would not suggest the combination therapy to any of my patients in private practice, even if their insurance would cover it. I would stick to the written standard, so I would still stick to either time-limited BCL2 plus monoclonal antibody or to the long-lasting BTK inhibition. However, I think that the question is very interesting, and I would persuade those patients to take part in clinical studies exploring this issue. I don't think we have enough data to recommend any particular doublet or triplet in our clinical practice outside clinical studies. But basically, we now treat over 50% of our chronic lymphocytic leukemia patients in a clinical studies, which is, I think, beneficial both for the patients and for NHS budget.
Thank you. If there is a question from anybody, just put the raise hand sign. Again, I will ask one more question. You said that MRD negative, you stop the treatment. When the MRD becomes positive, you can re-challenge the patient with the treatment. So once again, you will start the treatment at MRD. Will you start? The question is whether you will start the treatment at MRD positivity or only when the usual clinical indications are there.
Again, I would say that in my private practice, if I see private patients, I would never do any of this. I would just stick to the protocols which are the standards of care. However, if I were exploring that in a clinical study, it's a set of protocols, so I'll just follow the protocol. Personally, I think that we start receiving the message that if we have the MRD negativity in chronic lymphocytic leukemia patients, we can possibly stop their therapy and retreat them later. However, I want to draw attention to the fact that we have a lot of data showing us that BCL2 inhibitors work after BTK failure. We do not have that lot of data that BTK inhibitors work after BCL2 failure. And there are two different failures, because if we have patients failing Bruton tyrosine kinase, they are failing the ongoing therapy, and they usually just explode in a matter of weeks or months. If we are having a failure to BCL2, they are failing after the period of no therapy, and usually it's less harsh. So there might be different attitudes towards both. And perhaps one last comment is that we were lucky enough to treat over 100 patients with pirtobrutinib, which is this third generation BTK inhibitor. And yes, I may say there is a life after ibrutinib. I was not in favor of putting the patients to ibrutinib or other drugs in the first line, as I didn't know what to do with them in a relapsing refractory setting. Then we have BCL2 inhibitors, which was the first sign of relief, and now we have the second solution, the third generation BTK inhibitors. So I think that we can quite, if the finances allow us, we can take the BTK inhibitors to the first line, as we will know how to treat them in a second or third line once they relapse. If we analyze the pentafailures, that's the patients who failed chemotherapy, monoclonal antibodies, BTK inhibitors, first and second generation, IP3K inhibitors, and BCL2 inhibitors, so everything. Those pentafailure patients we treated with pirtobrutinib, and we had 60% response rate, long lasting. Once we had the patients who failed pirtobrutinib and they were not treated with BCL2 inhibitors before, we took them to we tried to treat them with BCL2 inhibitors, and the response to venetoclax was not perfect. So what I want to tell you in this is that whatever we know from the first and second generation of BTK inhibitors is not true for non-covalent drugs. They are different. And I see the question here from some chat. How long does it take for BTK inhibitor-induced initial lymphocytosis to settle down? And that is a very interesting question, because I'm warning all my patients that please be aware that your leukocytes may increase from 100,000 to 300,000. And the higher the increase, the better the drug works. So we can say that usually we observe it by 2 or 3 months, but it does depend from the tumor burden. I'm never afraid of high leukocytes as long as they are parallel with the lymph node mass or tumor burden reduction. If it happens, I'm reassuring the patient that it doesn't matter.
Thank you. Chirag, your question?
Yes, sir. From my talk last slide, how to manage patients on anticoagulation, one, and those who are having severe hypertension or active ischemic heart disease. And third category was those with low GFR, which has not been studied in formal clinical trials. These 3 categories.
Very good questions, thank you. Now, as far as population which is cardiologically impaired is concerned, they're not good candidates for ibrutinib. Now, you can certainly manage them with alternative anticoagulation. Drugs like Pradaxa or others are allowed. We use them somehow. However, I tend not to put my cardiac patients, so-called cardiac patients, on first-generation BTK inhibitors. I do whatever I may to put them on acalabrutinib or zanubrutinib. Now, how to put the patients with low glomerular filtration rate to the clinical studies, I have the rule of thumb, which means corresponding with the medicals. Because in most of the studies, they have the calculated glomerular filtration rate. And the calculated glomerular filtration rate, if you're talking about the elderly individual, which is skinny, is always down. It's always worse than the true GFR. So the first thing I'm trying to talk through with medical monitors is, please allow me to admit the patient to the hospital to do the proper creatinine clearance, and then we'll see. And in fact, majority of patients escape this way. And the third question was?
No, all you covered. If somebody's on anticoagulants actively, like warfarin or dabigatran, which you mentioned that you kind of use it, do you do any particular monitoring for them, or you start with lower dose?
Well, you can't be on warfarin if you're using BTK inhibitors. You have to change it to something else.
Okay.
None of even the second generation BTK inhibitors do not allow you to put the patients on warfarin. Whether this is reasonable or unreasonable, I have doubts, but that's how the scriptures are. Now, if you have patients really requiring anticoagulation, I usually try to treat them with the BCL2 based therapies. That's the answer.
Okay.
Unless they're high risk. If they're high risk, I play around with the anticoagulation. Sometimes I use low molecular weight heparin, because sometimes you want to know whether at all the patient will respond. So in these patients, I put them to the low molecular weight heparin for, let's say, 2-3 months, put them on second generation BTK inhibitor, and if we have the answer, if they are responding, if everything is fine, then I start playing around with Pradaxa and other drugs and keeping the anticoagulation efficient but allowed.
And what about recent MI, acute MI? How long would you wait? I mean, even for a second generation.
It does depend. Again, if we have, I would never treat the patient directly after the myocardial infarction. But if they fully recover this 4 to 6 weeks later, why not? I think that, sorry to tell you, but the more important thing is what you do with COVID. And in Poland, we have a situation where, unfortunately, we have a lot of unvaccinated people. The vaccination rate is not more than 60%, which is bad. So we tend to stop therapy, anti-lymphoma therapy, in all COVID patients. Frankly, the mortality, which was at the beginning of pandemics in unvaccinated patients, before we had Paxlovid or molnupiravir, it was very high. It was 30%. Now we came down to 5% mortality, and this 5% mortality was by stopping the study drug, was stopping any kind of anti-lymphoma therapy immediately, putting the patient on molnupiravir whenever you may, and then not going back to anti-lymphoma therapy unless, first, 10 days is mandatory. Then if they have any symptoms, until the symptoms are gone. So if the patient is having a fever or cough for 12 days, they are 12 days off the therapy. And then, and this is, I think, why we are successful, I'm adding additional 10 days. And this additional 10 days after cessation of symptoms have to be without any symptoms. Unfortunately, 30 to 40% of my patients relapse with symptoms within those 10 days. And then again, I wait until the symptoms are done, and then again, I wait this 10 days. So frankly, for COVID infection, we tend to stop therapy maybe for 40, sometimes for 50 days. And once we started doing it this way, the mortality went down. And sorry to share this house experience with you, but I think that in CLL, where you have the disease which is not very dynamic, you can do those things and they save lives. We can't be too overzealous with treating that immediately afterwards.
Thank you.
Thank you. Sandeep? Unmute yourself, Sandeep. Unmute.
With such excellent results with the third generation BTK inhibitors, where do you see the role of CAR T therapy and allogenic stem cell transplant in relapse refractory CLL?
A very good question, because I still remember the patients I transplanted, even if they were 65 or 75, and they got rid of the disease altogether. Now you have to balance risk versus benefit, and you have to speak it through with the patients. I very frequently look for the donors, see the mismatch, calculate the risk, sit with the patients, and we discuss it. I think the allo transplants are great therapies, but for very chosen population. I would not call it a standard of care, but I would call it an available option for those who are intelligent enough to cope with the transplant, to understand how shall they behave after the transplant, and certainly the condition is that they have an optimal donor.
Thank you.
Thank you. Any other question for him?
So I would say that I check for the donors maybe in 10% of the patients, but I transplant less than 3%. Talking about CLL.
Thank you, sir. Are you going to be with us for the rest of the webinar, or you'll be leaving now?
Well, it's up to you.
If you are with us, we'll be pleased. Thank you. So we'll go for the debate.
Sure.
Yes, sir. We'll go for the debate now. And we have high-risk chronic lymphocytic leukemia. Treat until progression is the debate. In favor is Dr. Rahul Naithani, who is Director, Hematology and Bone Marrow Transplant, Max Super Specialty Hospital, Saket, New Delhi. And against the motion is Dr. Satish Kumar A, who is Hematologist, Hemato-Oncologist, Manipal Hospital, Bangalore. So we begin with Dr. Rahul.
Good evening, everyone. Thank you, sir, for giving me this opportunity. And the topic that I have been assigned is management of high-risk chronic lymphocytic leukemia. And I will be speaking in favor of the motion, treatment until progression. So the treatment landscape of CLL has evolved a lot, especially in recent years. And we are spoiled for choices, so much that we are debating which agent to use and how long to use it. So since we are going to talk about high-risk leukemia, we should first understand what constitutes a high-risk CLL. So patients with deletion 17p have unfavorable outcome. Patients with deletion 11q, patients with TP53 aberrations do bad. Patients with unmutated IGHV, and patients who have complex karyotype. These patients so far have had unfavorable outcomes with the previously called standard therapy. Now, prior to availability of novel targeted therapies, we know that patients with TP53 or IGHV unmutated patients, they were doing badly in terms of survival. Now, chemoimmunotherapy is the prototype of the fixed duration therapy for chronic lymphocytic leukemia. It was limited in duration due to cumulative myelosuppression and the other adverse effects that it had. Now we know in 2022 that chemoimmunotherapy is no longer considered an acceptable first-line treatment for patients with deletion 17p or TP53 aberration. The paradigm of this fixed duration therapy has been challenged with the advent of targeted therapies with improving tolerance profiles now. There's still limited options available for patients who relapse early after first-line therapy, patients who have received multiple prior therapies, and frail or elderly patients with frontline or relapsed disease. Now, the phase 3 Alliance trials had clearly shown that PFS was significantly superior in ibrutinib-containing arm. At a median follow-up of 38 months, the patient with deletion 17p, the PFS had not reached, while it was bendamustine rituximab, the PFS was 7 months. So are we wanting to fix the duration of therapy, or we are actually trying to fix the progression-free survival of these patients by giving them a fixed duration therapy? The forest plot clearly shows that patients with high-risk cytogenetics, the ibrutinib-containing arms were doing better. The ASCENT trial had clearly shown at 12 months the progression-free survival for patients with deletion 11q with acalabrutinib was 90%, and it was significantly lesser in the other arms. The ELEVATE trial, which was discussed by the previous speaker, patients who were on acalabrutinib arm as a single or combination agent did much better whether they had deletion 17p or whether these patients had unmutated IGHV mutation, and patients with fixed duration therapy were doing badly. Again, the same question, are we wanting to fix the duration of therapy by giving them time-limited therapy, or we are trying to fix their progression-free survival? Now, this is the overview of the phase 3 trials in treatment-naive CLL. The alliance we discussed, the RESONATE, ELIMINATE, ELEVATE, CLL14, all these trials show significantly superior survivals in patients who receive BTK inhibitor or a continued or long duration therapy. CLL14 trial was one where they compared venetoclax Gazyva with Gazyva and the poor chlorambucil, and they showed significant superiority of venetoclax in this arm. This is the overview of phase 3 trials in relapsed refractory chronic lymphocytic leukemia. ASCENT trial, we had just discussed that acalabrutinib was doing significantly better. Murano was one good time-limited therapy which showed superior overall survivals compared to bendamustine rituximab. And RESONATE trial, we all know that ibrutinib was superior. The ICL CLL07 fellow trial, 135 fit patients without TP53 mutation, they were included. It was a combination of obinutuzumab, 15 months of fixed duration ibrutinib, and after month 9, 92% of the patients were not in BMCR. They received additional 4 courses of or FCR equivalent with FC with obinutuzumab. So these patients received obinutuzumab, ibrutinib, fludarabine, cyclophosphamide, again ibrutinib, and then they could get. So you have used literally everything in your hand except for venetoclax to bring deeper remissions in these patients. So what is the scientific evidence so far? So far, all phase 3 trials have clearly shown superiority of targeted agents over chemoimmunotherapy. Conversely, in Alliance and ECOG trial, there was no benefit of BTK inhibitor over chemoimmunotherapy for patients with mutated IGHV. So yes, there would be a population of patients who can go with a time-directed therapy and get good results, but that's a proportion of patients. For large majority, we continue to have superiority of continuous or ongoing therapies. Now, in current era, the time-limited treatments are basically venetoclax-based combination, either with an anti-CD20 antibody or with a BTK inhibitor. Now, data from CLL14 had shown that a superiority at 1 year with venetoclax arm, but again, it was compared with the chlorambucil. And we also need to realize that MRD assessments are still not widely available in India, at least for CLL. We at our center routinely do MRD analysis, but we understand. Also, the venetoclax for time limited, there is a dose ramp up with 20 milligram for first week, 50 milligram week 2, 100 milligram week 3. And then patients also need to be classified for their tumorless resist profile. And many patients end up getting admitted for 2 weeks just to take this oral tablet. That may not be feasible. The other challenges, venetoclax is not officially available in India. It's difficult to procure the smaller doses of 20 and 50 milligram for ramp up. And risk of tumor lysis, there are criteria of low risk, medium risk, and high risk. There are very few patients with low risk that we generally tend to treat. So a lot of patients would get admitted for just getting venetoclax. Now, what's the scientific evidence for fixed therapy? The most of the data available to date in frontline have been generated by treatment strategies of an arbitrarily fixed duration. So in CLL14 trial, the 1 year fixed duration of venetoclax was arbitrary. Similarly, it's a result of unplanned subgroup analysis in trials that tended to favor venetoclax combinations with or without anti-CD20 antibody, despite the absence of a straight head-to-head comparison. These are the major ongoing trials which are looking at fixed duration targeted therapies versus CIT or continuous immune therapy. And you would see that we are going to talk about the high risk CLLs, and majority of these trials have excluded the TP53 or the other high risk groups. We also need to be practical in our approach. We need to realize that CLL is a disease of elderly. Even the median age at diagnosis is 72 years. 70% of the patients are more than 65 years at the time of diagnosis. This is a search score to see the medical fitness, and if it is applied to all, generally we would see that 43% patients have minor comorbidity and 46% of patients will present with major comorbidity, and that might limit some of the therapeutic options that one may have in the hand. And clinical trials still of late were not reflecting the real life situation. The median ages of a lot of trials were much less than the median age of this. So much of these data were not even relevant for the large majority of population. Now the clinical trials have started to reflect the real life situation. Of course, there are valid concerns with ongoing therapy about the adverse effects. Generally, the ibrutinib, because most long-term data is available with ibrutinib. It was the first BTK inhibitor, and we know that a lot of adverse effects that we saw were because of the off-tumor or off-target effects of these BTK inhibitors. But now we know that these drugs are efficacious. Now we have second-generation agents available where the off-target inhibitors are minimal. The drug tolerance are very good, and these drugs could be continued for a long term in patients who have multiple comorbidities or are on multiple medications, including cardiac mobility. So what is the right approach for treating high-risk chronic lymphocytic leukemia? Now, numerous ongoing trials do demonstrate both physician and patient aspiration for time-limited therapies. Combining these targeted agents combinations are promising, but we should realize that follow-up is still short. The information on the efficacy of subsequent lines of therapy is still lacking. Sensitive MRD could help tailor the optimal duration, though there are concerns about MRD standardization and wider utilization in India at this point of time, but this is workable. Now, we also need to realize that the approval of the targeted agents was obtained through randomized trials against a defined referenced therapeutic regime like an age-adapted chemoimmunotherapy. The head-to-head comparisons of chemo-free regimes are still not available. And today, a decision between continuous treatment with BCR inhibitors and venetoclax-based combination relies mostly on comorbidities, co-medication, patient and physician preferences. Now, our understanding of the genetic background and clonal evolution is still not fully integrated into our therapeutic decisions. In the coming years, it could supplant the one-size-fits-all tendency of treating all patients continuously and allow for more personalized approaches, maybe MRD-tailored approaches when appropriate. But till then, ladies and gentlemen, it's continuous therapy for patients with high-risk chronic lymphocytic leukemia. Thank you.
Thank you, Rahul. Now, Satish.
Thank you very much, sir. I think Dr. Rahul has made my job very easy. He did present many of the slides which I wanted to present. So just one second. Sir, can you see my slides and am I audible?
You are audible, your slide is seen.
Okay. So what is high-risk CLL? We had only Rai Bennett. Now we have several prognostic indices to confuse us, but due to lack of time, I'll not go through everything. But as Dr. Rahul said, it's mainly TP53 aberrations, including deletion 17p or TP53 mutations, unmutated IGHV, chromosome 11 deletion, complex karyotype. These are the common ones. Now we have fewer more subtypes like B cell receptor, stereotype E, subtype 2, 1, and mutations in Notch1 and BRC3. Yes, ibrutinib has revolutionized the treatment of CLL, but it has some shortcomings. Dr. Chirag had mentioned that it is a continuous monotherapy. Deep remissions are rare. No one talks about MRD when we speak about ibrutinib or BTK inhibitors. And we know that if you stop ibrutinib, the disease is going to come back with vengeance. Half of the patients discontinue ibrutinib either due to resistance or intolerance. And when they develop resistance, the mutations can emerge. These mutations can emerge with time. It's not just in the first year. It can emerge in second year, third year, either in BTK or PLCG2, and it's very difficult to manage those mutations. Adverse effects continue to occur during therapy. It is not only in the first year we see atrial fibrillation or cardiac arrest and things like that. They do occur for the second year, third year of treatment. And imagine the cost of continuous therapy. Patients want to be free of treatment for cancer. I'm sure most of the patients, if we give an option of fixed duration versus continuous therapy, they would prefer fixed duration therapy. Venetoclax, yes, deep remissions have been reported, undetectable MRD has been reported, but as you see, the resistance is more than 50% with continuous therapy. So when we give continuous venetoclax therapy for several years, more than 50% of the patients develop BCL2 mutations, and they can develop clonal evolution, and it's very difficult to treat these patients who have failed venetoclax. So one of the things suggested is, if we stop treatment and retreat at relapse, the mutations or clonal evolution is quite less. So fixed duration combinations, the thing in CLL came up with muranitride. It was in previously treated CLL. The duration of venetoclax with rituximab was 2 years. And if you look at the high-risk patients subset, it was more than 50%, and the undetectable MRD negativity was 85.4% at 2 years in peripheral blood. And then we had the CLL14 trial, which again was a fixed duration, which was given for 12 months, and progress. The PFS was observed regardless of IGHV or TP53 mutation status. Rapid and durable MRD negativity, that is the word, sustained MRD negativity, was seen in almost 76% of the patients in the blood and 57 patients in the marrow. So the way to go is MRD in CLL. Even Rahul mentioned, Professor Jurjak mentioned that MRD is very important. If they're undetectable MRD, we can stop the treatment strongly. Even with chemoimmunotherapy, FCR patients, we know that patients who are MRD negative, undetectable MRD, they have strong or prolonged PFS and OS benefits. Increased depth of remission may lead to prolonged progression and progression-free survival and overall survival. Deep remissions may avoid resistant and eliminate the aggressive clones. So we need to take an MRD-driven decision-making in CLL. Coming to ibrutinib plus venetoclax synergy, I agree with Rahul that we should not use ibrutinib with monoclonal antibodies, venetoclax with monoclonal antibodies. But what about ibrutinib and venetoclax? This is a game changer. They are distinct, and the mechanism of action is complementary. They work synergistically to eradicate CLL, eliminating both dividing and resting leukemic subpopulation. They target different disease niches. BTK inhibitor most effective at clearing nodal disease. Venetoclax are more readily affecting cells in the bone marrow and in peripheral blood. So what happens is, in the lymph nodes, with close contact between the tumor and stroma, the CLL cells are well supported and they proliferate. With ibrutinib, the stromal cells, the addition to the stromal cells is disrupted and proliferation is halted. Ibrutinib, then the cells are released to the periphery, and ibrutinib prevents the homing of these cells again into the lymph node. And these cells now, without the supporting tumor environment, they become non-proliferating, and the resting CLL cells either die by neglect, but when we give venetoclax, they kill the cells, and that's why we have tumor lysis syndrome and disease improvement. So venetoclax mobilizes the CLL cells out of lymph nodes and other lymph node niches into the peripheral blood, where they are more susceptible to venetoclax-induced apoptosis. And inhibition of BTK by ibrutinib also enhances the dependence of these tumor cells on BCL2, thereby increasing the sensitivity of venetoclax, accelerating the apoptosis. So let us talk, we are talking only of high-risk CLL. This was one landmark trial published in NEJM, ibrutinib and venetoclax for the first-line treatment of CLL by Nitin Jain. It was a phase 2 study. 80 naive CLL patients, treatment-naive CLL patients, at least one of the following high-risk features: chromosome 17p deletion or mutation TP53, 11q deletion, unmutated IGHV, and elderly age. So combination of ibrutinib and venetoclax was given for a specific duration of 12 months. Look at the results. Outcomes were like 75% achieved undetectable MRD in the bone marrow. The 3-year PFS was 93%. 3-year overall survival was 96%. Mind you, this is all high-risk CLL patients. So the authors concluded that with a median duration of 33.8 months, 66% patients achieved undetectable MRD in bone marrow. Emergence of low-level disease in only 5 patients with no evidence of clinical progression. So if they have sustained MRD positivity, even if some of them develop low-level disease, there is no evidence of clinical progression. Fixed duration therapy with ibrutinib and venetoclax can lead to long-term responses, which allows for treatment cessation, which is an important thing for treatment. So then we have the Captivate study. Captivate, there was an MRD cohort and fixed duration cohort. Let us talk about the fixed duration cohort. Here, 159 patients, previously untreated CLL patients, were in the fixed duration. They received ibrutinib lead-in for 3 months, followed by ibrutinib and plus venetoclax for 12 months or 1 year. And then upon progressive disease, retreatment options included continuous ibrutinib or fixed duration ibrutinib and venetoclax. Look at the patients who had high-risk features: unmutated IGHV, 56%, deletion 17P or TP53, 17 patients, deletion 11Q, 18 patients. So most of the patients had high-risk disease. One of the most important conclusion I can say is 92% of the patients completed planned 12 cycles of combined ibrutinib and venetoclax. If you see the dropout rates with only ibrutinib and venetoclax, there are more than 30 to 40% dropout rates in all the trials. In real-time world, it is you can see it's more than 50 to 60% due to comorbids, due to intolerance, due to mutations. So here, 92% of the patients completed the treatment. Again, if you see the results, the overall response rate in this Captivate fixed duration was 96%. 52% of them achieved complete remission rate, and 77% of the patients developed undetectable MRD in the blood, and 60% patients had undetectable MRD in the bone marrow. So because this debate is all about high-risk features, let us compare the high-risk CLL to those without high-risk CLL. So 129 patients, majority of the patients in this Captivate FD had high-risk features compared to 73 without high-risk features. So if you see, surprisingly, the results were better marginally in patients with high-risk features in this Captivate FD study who received both venetoclax and ibrutinib. The CR bar CRI was 56.6% compared to 49%. Durable CR, 87% compared to 95%. Overall response rate, 98% in high-risk features compared to 96%. Undetectable MRD in peripheral blood, 88% compared to 70%. In bone marrow, 72% compared to 62%. What about the 2-year-old progressive free survival? 94%, 97%. Overall survival, 98% and 100%. Has any other trial given such a good result in high-risk CLL? So the estimated 36-month progressive free survival was 88%, and similar rates were seen in patients with TP53 mutation or deletion 17P mutated, or even in unmutated IGHV. The estimated 36-month overall survival was 98%, and similar rates were seen in all the high-risk groups. Retreatment, there were 12 patients who progressed after fixed duration who have been treated with single-agent ibrutinib with duration ranging from 6 to 32 months, and many of the patients achieved partial response. Only one patient had stable disease. Most of the side effects were grade 1 to 2, which occurred within 4 to 3 months, which is an excellent thing because very few patients discontinued therapy due to adverse effects. So the authors concluded saying that the fixed dose ibrutinib and venetoclax continues to demonstrate deep, durable responses and clinically meaningful progression-free survival rates at 3 years, including progression-free survival of more than 80% in the high-risk groups. With an additional year of follow-up, no additional overall survival event occurred. The safety profile was manageable and unchanged from that previously reported. Most of them were low-grade adverse events. Early data suggests that patients who previously early data suggested that patients who progress after fixed duration treatment with ibrutinib and venetoclax can be successfully retreated with single-agent ibrutinib, and ibrutinib venetoclax represents an efficacious all-oral, once-daily chemotherapy-free fixed duration regimen for previously untreated patients with CLL. So I would like to conclude with this slide. Ibrutinib and venetoclax fixed duration treatment regimen increases the depth of remission, may lead to prolonged progression-free survival. There are non-overlapping toxicity profiles. Most patients completed treatment in all the trials showing the fixed duration protocols. It reduces the potential for ongoing long-term toxic effects because we use it for only 1 year. Decreases the likelihood of drug resistance as shown in the previous slides because you give it intermittently. The cells are not exposed continuously to the drugs. And in India, cost is lower rather than giving venetoclax continuously or ibrutinib continuously. Definitely it has a financial benefit. And we are talking of TFR even for CLL patients, just like in CML patients, we are talking of treatment-free remission for patients. So the thing to go is MRD guided time limited therapy. It is better than treatment still progression. I'm not telling fixed duration therapy, use it for 1 year, 2 years. It has to be MRD guided. and MRD guided fixed duration therapy definitely would be the future of CLL. Of course, we need more evidence, but looking at if this debate happens after 2 to 3 years, I'm sure even Rahul Nathani will vouch for fixed duration therapy, which should be MRD guided. Thank you, sir.
Thank you, Satish. Rahul, any rebuttal?
Yes, so I must congratulate Dr. Satish for nicely putting the data. The first thing is the patients want fixed duration, physicians want fixed duration. Of course, everyone wants fixed duration. We want all diseases to be like malaria, give chloroquine for 3 days and you're done. It doesn't happen in hypertension, it doesn't happen in diabetes, and in CLL is still evolving. Dr. Satish talked about the cost. Venetoclax is not even officially available in India. You import it through a proper route and see what the costs are like. The drug availability is a huge issue. MRD, certainly ibrutinib doesn't cause MRD negative, but then that's the reason we are giving it continuously. Patients with hypertension take medicines continuously, they do well. Patients with diabetes take medicines continuously, they do well. We don't have MRD guided something there. Of course, we would want a fixed time limited duration. As of now, in 2022, the data is not robust enough to say that yes, there would be a proportion of patients who might benefit with a proper standardized MRD available, a proper legal venetoclax available, where patients are in hospital for 2 weeks, they're able to manage all those costs. And so yes, there may be, all of us have 5% patients who can, afford anything and everything. So they might actually go for it with favorable risk profile and tolerance and an adequate response. There may be a small subset which would go for it. Now, as our guest speaker has already talked, we know when ibrutinib doesn't work, venetoclax works. We don't know what happens, the vice versa. So using venetoclax upfront in newly diagnosed patient, the follow-up data is very short. We don't know. Even though we talk about Western world, the median age is 72 years. In India, the median age of CLL is 55 years. And if these patients, try to relapse after 4 or 5 years of ibrutinib and venetoclax, we do not know what more do we have to offer. Lot of these drug combinations come as magic bullets, all the diseases that this drug just brings a remission. And the moment you see the long-term follow-up data, majority of them fizzle out. I mean, so far, there are very few medicines which have stood the test of time, like imatinib. Majority of the drugs on a longer follow-up do not show that. But then, yes, I do agree that there may be a small proportion of patients which might be able to take time-limited therapy. But as I concluded, till that happens, all the patients with high-risk CLL continue on a continuous therapy.
Thank you, Rahul, and thank you, Satish, for that very exciting debate. We come to the last part of the webinar, and that's the question and answer session. I'll just share some screen again. It's my pleasure to introduce the additional faculty who will be joining us. I will be moderating this, and we have, again, very important personalities. Dr. Sandeep Shah from Ahmedabad, Dr. Tufan Dolai from Kolkata, Group Captain Dr. Harshit Khurana from Pune, Dr. Mobin Paul from Kochi, Dr. Sterling Bala from Hyderabad, Dr. Amrita Ramaswamy from Gurugram, Dr. Sumit Nirk from Mumbai. So we have some questions here. And the first question is, which is the most important test for diagnosing CLL? So something very basic. As we do not have much time, we'll ask one of the faculty to answer. We can take a comment from Dr. Wojcik and then move on. Okay. So anyone?
Yeah, this is Dr. Stalin. Hello?
Yeah, okay, Stalin, go ahead.
Whenever you see a case of suspected CLL, the most important test to diagnose it is the immunophenotyping. So upon the expression of the markers like CD5 and 23, so we confirm it as a CLL, and then once the diagnosis is confirmed, we move ahead with the test to prognosticate it, whether it is a high risk CLL or low risk CLL, based upon the FISH panel.
All right. Dr. Wojcik, you want to give a comment? He's muted and I think it's frozen. So we'll move on. We go to the next question, and that is, which is the most important test for prognosticating CLL?
Yes, Dr. Tufan here, sir.
Yeah.
In terms of the prognosis, as we know from the different trial and the study, that the 17p is very, very important. The TP53 is very, very important. Deletion 11q is very, very important. And also the unmutated IBGB is very, very important. I think in clinical practice, the 17p deletion and the 11 and also the complex karyotyping and also the unmutated IBGB mutation is sufficient enough. Apart from that, in the flow cytometry marker, though the JAP70 and the CD32 expression has some role, but the molecular 3 to 4 things is very important in terms of prognostication.
Thank you, Tufan. Dr. Wojcik, you want to give some comments? Okay. We'll move on to the next question, and that is, what exactly is your definition of high-risk CLL? And I think this got discussed in the last session very adequately. The next question is, which advance in the pharmacotherapy of CLL excites you the most? Which advance in the pharmacotherapy of CLL excites you the most?
I think the combination of venetoclax and ibrutinib, which is already discussed, because it's a finite therapy, and if MRD guided, then just like CML TFR, we can have a fixed therapy and patient can have a treatment-free long remission. So I think that combination is the most exciting, and long-term results, if promises the early data, then I think it's the most exciting combination.
So, sir, not just patients, even Dr. Sandeep Shah is with me, sir.
Okay. I'm only not sure whether high-risk patient at this stage, you are very comfortable in giving a fixed duration therapy.
No, sir. No, sir. No, sir. For the sake of debate, I agree. But high-risk patients, even I would be afraid to give. But, sir, it will become a reality in few years. I mean, when you gave me the debate, I thought it was CLL fixed duration versus this thing. When I got the next mail, it was high-risk CLL. Then I thought I lost the debate. But when I looked at the evidence, there is a lot of evidence coming up. As of now, in practice, I don't think so we'll stop ibrutinib at 12 months. But, sir, there is a lot of data coming up, and I'm sure they're comparing fixed duration things to many other things. So in few years, I'm sure we'll be talking of TFR, which would be MRD guided. That is the key, sir, MRD guided. Now everyone agrees, even Rahul will agree, that if MRD is undetectable, we are safe in stopping therapy in a subset of patients. This subset of patients slowly should include the high-risk patients, sir.
Thank you, sir.
And the important thing is there is a response again if they relapse. So with the same therapy, if they relapse after 3 years, then the same therapy is equally effective. So
yes, sir. And they will not have the resistance clones also, because you have given for 1 year, most of them will not have any resistance clone.
Until that happens, it is spontaneous therapy.
Yeah, I think it's good to discuss it in debate and be different in the practice. Dr. Wojcik, are you there with us? No, okay. So we go to the next question. And this question is, do you think that the CD20 antibody is losing out its space in the treatment of CLL in front of BTK inhibitor and BCL2 inhibitor? Is the CD20 antibody losing out its important space in the treatment of CLL?
Yes, sir.
Amrita is taking it up. Yeah.
Yeah. So I think CD20 monoclonal antibody is got its own place in the treatment of CLL. Obviously, if we have an IGHV mutated person, chemoimmunotherapy is the way to go. In combination with a BTKI inhibitor, obviously there is no trial which has demonstrated, a greater overall survival or a greater progression-free survival for the combination vis-a-vis BTKI monotherapy. But obviously, monoclonal antibodies have a role in combination with venetoclax, rituximab with venetoclax in the relapsed refractory setting, and venetoclax with obinutuzumab in the upfront setting, where we are looking at time-limited treatment options.
Right. Anybody wants to support her or differ from her?
Yeah, I want to support, sir. This is Dr. Salim. So, yeah, so at least in the IGHV mutated cases, still there is a role of finite therapy using the CD20 monoclonal antibody.
Okay. Dr. Wojciech has said that his camera is not working, but he can hear us. So, sir, tell us something.
Yes, absolutely.
Would you like to comment on this, whether CD20 monoclonal antibodies are losing out?
I love time-limited therapy. I think that for those patients who are willing to come to the hospitals, are willing to come to IV infusions and a mobile, this is the best option. Now, if you have a low-risk patient, this is what I offer them. The problem I have is with young patients who are fully fit and who a couple of years ago would be candidates for FCR or something else. So low risk, young patients, but I still offer them time-limited BCL2 inhibitors, plus obinutuzumab, first line.
Will that get challenged by the combination of BCL2 plus BTK?
We don't have it approved. So if I have a study, absolutely so. If I do not, we can't.
Right. Thank you. We'll move on again. And we have the next question is, can you use EHA monotherapy as a blanket treatment for all patients of CLL requiring treatment, that is newly diagnosed, relapse setting if they've not used it upfront, young, elderly, low risk, high risk? That's the question. Yes, we will take this up.
Okay, not for a low risk patients like an IGHV mutated cases, sir, where I will be offering the fixed duration of bendamustine plus rituximab. Hello, sir. Am I audible, sir?
Background noise.
Oh, sorry.
Okay, okay. Anybody else?
Sir, can I make a comment here?
Please, Sumit.
Yes, sir. So, acalabrutinib as monotherapy in all patients, yes, it sounds wonderful. But for young patients who are IgG mutated, I would still prefer an FCR-based or CIT-based regimen. We have to discuss about indefinite treatment and the finances before we embark on using indefinite BTK inhibitors. Because as the debate suggested, there are many patients who might prefer a time-limited therapy, and then we need to discuss about indefinite treatment with them before giving them acalabrutinib.
Thank you, Sumit. One question I have for Dr. Wojciech. How much is your concern about using FCR in young people with respect to later on developing MDS or other myeloid malignancies? You'll have to unmute yourself, Dr. Wojciech. I think he's facing difficulty. Anybody wants to add anything, or we move on?
If it is
So 1 minute.
Yeah, Dr. Wojciech.
Ladies go first, sorry.
Okay, Dr. Amrita.
I'm saying that if it were AstraZeneca event, I would say that acalabrutinib is nice for everything. Now, as it is not AstraZeneca event, I will say that acalabrutinib, zanubrutinib are very good drugs, but I would definitely not offer them to everyone. I would selectively treat with them high-risk cases requiring therapy, relapsing refractory or first line, but just high risk.
And your comment on FCR for young people with mutated disease and any risk of future MDS or AML?
I was brave enough to stand in front between Professor Halleck and Professor Zimbalista, and I told them that FCR is an awkward regimen. Now, there is only one thing worse than the FCR or BR regimen, a meticulously dosed FCR regimen. So if we have to use it, we have to look at the patient and reduce the dose so that at the end of the day, we don't have a prolonged cytopenias and long-lasting problems, and perhaps reduce the number of cycles. Because the condition of having the patients alive or having the patients long with us is to keep them alive and not to kill them with overzealous therapy.
So a protocol like IFCR 4 cycles?
Yeah, you look at the patient, you look how well he tolerates, and you look how he responds. But in this respect, with the traditional chemoimmunotherapy, I rather look at the clinical response and not an MRD.
Right, sir. We'll move on to the next question. We are running out of time. And the next one is, what strategies do you use for preventing infections in chronic lymphocytic leukemia? Sumit?
So we routinely give vaccinations to all our CLL patients, irrespective of their need of treatment or not, need of CLL treatment or not. And the vaccinations specifically are influenza yearly, and the pneumococcal polysaccharide vaccines every 5 years. IVIGs if they have history of hospitalizations of serious infections, say more than 2 to 3 episodes a year. And with more and more incidence of atypical infections with ibrutinib, ceftriaxone prophylaxis for covering the PCP in patients on ibrutinib or who are on FCR-based regimen, hepatitis B-based prophylaxis, especially for those who are core antibody positive or HBV DNA positive or HBsAg positive, for patients who are going to receive anti-CD20 monoclonal antibodies.
Okay. Anybody wants to add? Otherwise, Dr. Wojcik?
May I just share my screen to show you one more slide?
Yes, sir.
It's a CLL14, and that's this one. And it's very provocative. That's the MRD after there was 4 arms. So you have chemoimmunotherapy arm with 52% of complete regressions MRD, then venetoclax plus rituximab, 57, and then look what happens if you have venetoclax plus obinutuzumab. It shoots up to 86, and it's just the difference between RV and GV was just venetoclax was given in both of them, but it was just rituximab versus obinutuzumab. But the most interesting for me is the fourth arm, where you have additional BTK inhibitor. So we have venetoclax, obinutuzumab, and BTK inhibitor, and you see not a great difference between just venetoclax plus obinutuzumab. And so this is on this slide from CLL 13 study. I would just like to show you. And now I want to stop sharing the screen.
Okay. We have one question in the chat box. How would we go about sequencing therapies in chronic lymphocytic leukemia? Anybody wants to take it up? Sequencing therapies in CLL.
So in CLL, just like in myeloma, we have sequencing of therapies. I think it's very important that we sequence therapies in CLL also, especially in a country like India, where we do not have access to all drugs. As Dr. Rahul rightly pointed out, we do not have access to venetoclax in our country. So we cannot actually think practically of, an ibrutinib and a venetoclax combination or an acalabrutinib and a venetoclax combination in India yet. So I think in India, it's all the more important that we sequence therapies. So start off with a BTKI if it's high risk, or again, acalabrutinib is not a blanket treatment. If we have a younger, fitter patient without comorbidities, we can still consider ibrutinib. So I think sequencing of treatment is very important. And as all the other panelists have pointed out, we do not have much data if venetoclax is used upfront, whether BTKI really works as well. So I think sequencing is important, and especially in a country where we have limited resources, I think it's very relevant, and I don't think it's very impractical talking about, ibrutinib and venetoclax combinations and acalabrutinib and venetoclax combinations.
Thank you, Dr. Amrita. Any comments from Dr. Vaichak? Sequencing therapies in CLL treatment.
We have to give our patients the best therapy. So if the best therapy could be time limited, it's time limited. In high risk cases, the best therapy is long lasting BTK inhibition. So we should go for it. Now, if we follow this in a relapsing refractory setting, it will possibly happen in a couple of years' time, and we'll have more knowledge about the adequate combos.
Thank you. We'll move to the next question. This is a question related to low dose ibrutinib instead of the standard 420. Any experience anybody wants to discuss?
Sir, I would like to share one thing.
Yes,
so there is one in vitro data from Dr. Nitin Jain's group, wherein they had a small study of 10 patients, and they saw that even at lower doses of 140 or 280, the BTK occupancy rate was more than 95%. And interestingly, that also had a lesser inhibition with respect to the platelet function inhibition. And there is one retrospective data which says that the event-free survival and overall survival is same in both the groups of low dose as well as standard dose ibrutinib. So approximately 2.5 years back, we have a 4 patients who are having cardiac comorbidities. They actually deserved acalabrutinib, but we couldn't because they have financial constraints with respect to acalabrutinib. And after a lot of discussion with the patient, because they were 17p deletion or they had relapsed within 2 years of chemoimmunotherapy, they were given low dose ibrutinib. Unfortunately, all 4 of them have been doing well in the last 2.5 years. They have achieved a response, and they have not had greater cardiac side effects. Obviously, hypertension has been an issue while managing them, whereas each of them has been on at least 2 antihypertensives. But fortunately, they are doing well till now.
Any data in that paper about development of resistance, mutations?
So that is the only data which is not there. I asked this on international forum to one of the speakers also, but as per them, that is the only hindrance of the use of low dose ibrutinib.
I think Dr. Agarwal sir, yes, this is the low dose ibrutinib, but also in my clinical experience, people is taking the 280, there is a good tolerance in there. And also the effectivity also good, but we need to follow up long run to exactly how the low dose is working, how the mutation is developing or not. But yes, the low dose is also working in my clinical practice.
Sure, Dr. Vaichak.
I remember that the first patient I treated with ibrutinib was in 2007. Now, it was registered and approved in 2013. So aren't we close 2023 when it will become generic? And if it's generic, perhaps the question of a low dose ibrutinib is the old question. But answering your question, I remember one of my first patients, and he couldn't get ibrutinib. Otherwise, the ibrutinib was not refunded. We didn't have the study at that time, and he was a doctor, so he came to the conclusion that he will use antifungal with ibrutinib, and went down to 140 milligrams a day. But certainly, this is not recommended.
Right.
And fungal just efficiently rose his ibrutinib levels.
Thank you. Let me see if there are any more questions. Okay. How often do you do ECG in a patient who is on BTKI? Also, should we change from ibru to acala if patient develops atrial fibrillation, or we can continue ibru itself together with antiarrhythmic medicines? Long question, yeah.
Yeah, the instance of atrial fibrillation, this is challenge. So the instance of atrial fibrillation is quite high with ibrutinib compared to the acalabrutinib. So how often we do ECGs? We definitely do it at baseline, and the incidence of atrial fibrillation is more common during the first 6 months of treatment. So we can do it if the patient becomes symptomatic, or as the incidence is very high in the first 6 months, we can do at least once in 2 months for the 3 ECGs for the first 6 months. Once the patient develops atrial fibrillation, so now we have a generic acalabrutinib also, and the incidence is around 4 to 5%. Definitely, if the risk of if the atrial fibrillation is high, we can switch over to acalabrutinib because we have a generic and almost the both are at the similar cost, and the incidence of atrial fibrillation is very less with acalabrutinib. So if the patient can't afford acalabrutinib, we can continue with a rate control using a rate control medication like a beta blocker, which is indicated for the treatment of atrial fibrillation associated with ibrutinib.
Thank you, Sterling. Anybody else wants to add anything? Otherwise, we'll have a remark from
Perhaps,
yes.
Perhaps that if in the countries where both ibrutinib and acalabrutinib are available, the price of acalabrutinib is the same as the price of ibrutinib. So my question is, why on earth use ibrutinib in the first place? If the costs are compatible, I would be very confident in starting all the patients on the second generation BTK inhibitors.
Absolutely. Perfect. You're right. Okay. Let me see if there are any more questions. Okay. So what is the biggest challenge that you still face in treating CLL? It's a philosophical question. What is your biggest challenge in treating CLL?
I think, sir, the biggest challenge in India is the availability of the drugs, and the second is the financial issue.
So those
and the third thing is the monitoring
scientific
of the MRD. I think this is the 3 to 4 things is very challenging.
Those are local issues. Any scientific issues? What about MRD and its placement in the treatment? Is that an issue? Okay, Dr. Wojciech, directly to you. What did your practice the biggest challenge?
I would say that for me, the biggest challenge in CLL is cytopenias. And I will try to defend myself because with the abundance of clinical studies we have and abundance of options, I understand that relapsing diseases, refractory diseases exist, but you can always choose something unless the patient is having a profound cytopenia and he simply does not tolerate any of the drugs you give them. So it's provocative, but for me, cytopenias are. And that's why I so very much not like patients being treated with fludarabine, cyclophosphamide, and rituximab up front, because we still see the patients once they are relapsing and refractory, and they are in a dreadful condition because you want to treat them with the modern targeted therapy, but you can't because they are cytopenic.
Thank you. Okay. So are there unanswered questions in the management of CLL left? Unanswered questions in the treatment of CLL. So somebody had asked Dr. Wojciech about CAR-T therapy. So what's the progress on that front and how do you see the future?
I think the results with CAR-T therapy surprisingly are not good in CLL. Unlike other B-cell disorders like ALL and diffuse large B-cell lymphoma, the results are not encouraging in CLL. So, and with so many good drugs are available, I think CAR-T therapy won't be that successful in CLL.
Yeah, but Sandeep, at the end of the day, you still end up with young people who have exhausted their medical treatment and they're still in their 55, 60, and you helplessly are looking at them offering allotransplant as the only option left, as you put it rightly some time ago. Yeah. So CAR-T comes up, then you have two options, if it comes up. Whether this is early days, innovation may help, or this will never happen. I'm not sure. If Dr. Wojciech has some data, some more information.
The immunotherapy in CLL is, I would love it were effective, but I simply have the impression that most of our patients are with so severely impaired immunity that trying to make something out of it may not be effective. Again, I think that we are talking about all those nice opportunities we have, but at the same time, each of us have still patients treated according to the old standards of care, where there was a lot of chemoimmunotherapy given, and those patients are very prone to infections, very they have a lot of comorbidities. So I simply think that boosting immunity would be the great idea if we did it up front. But with the present relapsing refractory population we have, it might be difficult.
Right, so loss of immunity is a big problem. Yeah. Anybody wants to ask anything to Dr. Wojciech before we close the day?
If I may ask a question.
Yes, Samrita.
Sir, how important is it to do, a FISH or a molecular testing at a relapse that is more than the first relapse, that is greater than the first relapse? Is it your practice to do it at second relapse? Do you look at the molecular tests routinely, or does it become irrelevant at a greater relapse, like a second relapse or a third relapse?
Sir, you are muted.
It's quite a difference what we do as a standard and what we do in a real life. The real life is that long time ago, we hit upon the idea that kicking gold clinical research out of university and making it all private is profitable. So we created one of the largest clinical study centers in that part of Europe. We are currently concomitantly running about 70 studies in lymphomas and CLL patients. So we always have something to offer to our patients. And that was done primarily because none of the new drugs were funded in Poland fast enough to make us happy. So if you're asking, do I do the testing? The answer is yes, I always do the testing because it's always required in clinical studies. If you ask me, would I do the testing in NHS-treated patients, which I would have to treat outside clinical studies? The answer is possibly I would not, because if I were treating him with targeted agents, regardless what the results were, I would still have no other options than to treat him with targeted agents. So yes, it's very interesting. Yes, we would like to do it. Does it change our practice in relapsing refractory setting? I doubt. And whatever you say, I just want to share the idea we had that we so successfully developed in our country. We had, and always a question, should we carry on with the clinical studies at the university hospital? And we always had, sad to say so, queues of patients for chemotherapy. And we found it ethically wrong to treat the patients within clinical studies, which would bypass the queue, and to treat the patients with NHS therapies, which would have to stand in the queue. So that's why we took all the patients within clinical studies elsewhere. It's funded separately, it's done separately, and it helps us because at the moment, I would say that half of our patients, lymphoma and CLL, are treated outside NHS in clinical studies. And as it is done privately, it is done efficiently. We have all the personnel we need. We earn good money there. NHS does not pay for it. So this is the way we function because we are a poor country.
Thank you. Thank you. So I suppose with that we come an end to the scientific session. On my behalf, I thank everybody and now hand over the platform to Dr. Shweta Surve to give the official vote of thanks. Shweta.
Thank you so much, Dr. Agarwal. I think it has been a fabulous evening, very engaging discussions. Thank you so much, Dr. Wojcik. It was a very lucid presentation on all the ASCO and EHA updates on CLL management. Thanks to all our speakers for that elaborate presentation and the nail-biting debate session which we had. I think it was very interesting to hear that. Thanks to all the panelists for asking those questions and keeping this so interactive. Thanks to Perfect Square for their logistics support and the audience for being a part of this discussion. Thanks, everyone. Have a very nice rest of the day. Good night and take care. Thank you so much.